Hello, my name is Dr. Joseph Sakamura. I'm the Director of Clinical Innovation here at the American Institute of Balance, as well as one of the primary faculty in both our vestibular and concussion rehabilitation certification courses. Our topic of discussion today is alternative methods of Canalith repositioning. Being a research institute, we at AIB have a database of just over now 16,000 patients on whom we've performed successful Canalith repositioning. And what we're going to talk about today, using some of our evidence-based protocols that have been developed, and also a lot of the publications and scientific contributions that we've made, we're going to walk through how to manage treating patients that have BPPV, but that maybe not appropriate candidates to have traditional Epley maneuver. And what I mean by Epley maneuver is a rotated, hyperextended, head off the table kind of a maneuver, like are still taught in a lot of textbooks and these kind of things. So we've likely all run across a situation clinically, or at least those of us that are doing Canalith repositioning and doing BPPV treatment, in which a patient, maybe they're bariatric, maybe they've got comorbidities of the thoracic or the cervical spine, spondylosis, kyphosis. Maybe they have, lower back pain or shoulder problems, or have any of these number of biomechanical issues that make them a little bit challenging to deal with when working them through the progression of BPPV treatment. So today we're going to talk about some of the other options that exist. What's really important to focus on for today, though, is that everything that we're going to show you in terms of the elicitation and treatment techniques that we share with you are rooted deeply in evidence-based science. There are a lot of protocols and treatment techniques and repositionings that you can find if you go to Google or to YouTube. It's just important for our purposes today that we all understand that these are not only developed here at the Institute, but also studied vigorously and again published on in a number of peer-reviewed journals. So when we talk about BPPV, we all know that this is a result of displacement of otolithic debris, in other words, little calcium carbonate particles, crystals, if you will, that have become displaced from the utricle into one of the three semicircular canals. Today, our topic of discussion, our point of interest, is going to be the posterior canal, because we know that the literature supports about 90% of cases that are seen clinically are of posterior canal origin. So understand that the horizontal canal may be involved, the anterior or superior canal may be involved, but most commonly what we're working with are posterior canal cases. So pictured here is basically just a little graphic representation of what this looks like. So you can see the little black dots within that posterior canal are our otoliths. These are our debris. These are our crystals. They're supposed to be housed within the utricle. So they're supposed to be here. But what's happened in BPPV is that these little gravity sensing particles that again are supposed to be here have gotten displaced or moved into the canal itself. Now, when we think about this, we've got a gravity sensor, again here, and we have a head movement or velocity sensor here. What happens when we get gravity sensing particles into a velocity sensing canal is that the patient experiences, again, transient vertiginous episodes that are short-lived, usually with the posterior canal, about 20 to 30 seconds, but very, very debilitating and can be quite violent. So the treatment for these, it's important to understand that both the test, so the modified Hallpike or side-lying Hallpike, like we're going to show you here, as well as the treatment, are simply designed to put the ear into different gravity-dependent vertical positions in order to progress this debris back into its designated area. So BPPV is a mechanical condition. It's not nerve damage. It's not necessarily even a pathology. It's not something that it's benign in nature, but it's a mechanical displacement. And in order to fix the problem, we simply need to move these crystals back home. Move the sand through the shoe, move the marbles through the maze. And that's just what's shown here, is that at the end of the day, whether you're doing Epley's maneuver, whether you're doing Semant's maneuver, whether you're doing the Gans maneuver like we're going to show you, the way that treatment works is you have to progress these debris through the different arms of the canal until eventually, again, they drop down back into their designated area. And we know that the gold standard of number of treatments needed to fix this is about 1.25. That's not treatment sessions, that's treatments. So the conceptual knowledge of BPPV treatment or Canalith repositioning is actually really quite simple. Move the ear into positions where the debris can eventually work its way back into the utricle. What makes repositionings a little bit challenging are the number of other medical comorbidities that these patients may present with. Now, often these are biomechanical, neck problems, back problems, pain, mobility issues, but part of this may also be contributed by psychosocial issues. They're having panic, they get nervous, they don't want to lie themselves in these different positions that may provoke their dizziness. So there has been a desire, a striving in the literature to come up with maneuvers that are comfortable and that meet the biomechanical needs of more difficult to treat or more involved patients. So what we're going to show you is that every treatment goes through these different progressions. The head position should always move into these different segments, but what you can modify is the position of the body, and that's what we're going to teach you how to do in the next couple of slides. So what this slide is basically demonstrating, I just wanted to put this in here just to quickly let everyone know that the 3 treatments that we teach in our certification courses, should you come take one with us and become certified as a therapist, physician, audiologist, is we actually teach 3 posterior canal treatments. The modified Canalith repositioning, so almost the traditional Epley variant. It's listed here as CRM. We also teach the SLM, the Semant liberatory maneuver. And that's dictated here as SLM. The one we're going to talk about today is highlighted in blue. This is the Gans repositioning maneuver. And what we want to share with you is that when you compare these studies, the difference in terms of clearance rate, in terms of efficacy, is negligible. So these treatments can all be used with confidence. But what's really interesting to look at is if you look at the rate of recurrence. Epley's traditional maneuver, 30% chance that his patients recurred. If you look at now the gold standard, the Semant maneuvers, and the Gans like we're going to go through today, this is really what we ought to be shooting for, is closer to a 5% recurrence rate. That's the gold standard. But this is just to kind of demonstrate throughout the publications, throughout the studies, we know that these can be used almost interchangeably, again, to meet the patient. So when we talk about techniques to elicit BPPV symptoms, what we're of course referring to are positional tests. So a lot of you probably have heard these referred to as Dix-Hallpike tests. Everything that we're going to share with you and show you is going to be fully supported and maximize patient safety and patient comfort. So rather than doing traditional Epley, Hallpike style test and treatment where the patient's head is almost dangling off of the table in a rotated, extended position, everything that we're going to show you is again going to be hybridizations or modifications of bed transfers. So the fully supported Hallpike being one approach to this. The one that we're going to focus on today when we talk about the Gans repositioning maneuver is going to be the side-lying Hallpike. This was originally developed and tested by Helen Cohen and her group, looking at how we're able to put the ear into a vertical position, but without actually having to have the patient's head in a hyperextended, rotated position. This is also what Semant in his original work looked at were side-lying position tests. Lateral body positions, again, these are for the horizontal canal variant, which we're not going to touch on today. Again, less common, about 10% of cases, anywhere from 8 to 10% of cases. We do talk a lot about the horizontal canal variant in our courses, but for today we're going to focus on the side-lying and on the Gans repositioning posterior. So what we've got here is a side-lying assessment test. So what we're doing is we're looking at a test that puts the patient's left ear into a posterior canal vertical gravity dependent position. And what we can do is that we can satisfy all of those parameters. We can put the head into that position without having to have the patient sort of long sit on the table and dangle their head off of the back. And that's what the video here is going to show you. So he's going to, rather than have the patient sit, turn their head and lie flat on their back, he's going to have her turn over to her right and simply lie down on her side. And what you might tell a patient when you're doing this is you're just going to lie down into bed. And that's, again, a much more comfortable approach, and we prefer to use this with our patients that have a positive vertebral artery screening test. Again, if someone does have a vertebral artery compromise or insufficiency or any of these number of issues, we would rather not put them into a rotated hyperextended position. So again, safety and comfort is maximized here. So that's the elicitation test. Again, in this video example, the patient would have been negative, no nystagmus, no vertigo, and he simply would have sat her up. So now what we've got is a real patient video. So you're going to see nystagmus and vertigo and these kind of things. And what you ought to notice here is that, again, the demographic of most of our patients are going to be the older adults. What do older adults often come with? A whole laundry list often of other medical comorbidities, be they biomechanical or otherwise. So in this video, look at just the comfort of how the patient is simply asked to lie down on her left side with her head turned. Notice also the severity of, she's having an attack of vertigo. She's clearly not comfortable. So he's able to observe the nystagmus here, and rather than being, head hanging off the table, difficult to orient herself to gravity and to what's up and what's down, she's simply in sort of a swaddled, almost bedtime type of a position. So again, he's going to look for nystagmus, look for subjective vertigo, and now he knows that this was a positive side-lying Hallpike test. So he's ready to go ahead and progress now into the treatment, which we're going to show you in the next slide. But keep in mind that the need for these modifications to these treatments, again, is largely patient-driven. It's very rare that you have a person with wonderful range of motion and no nervousness, no anxiety with these symptoms. So you've got to keep in mind that while it doesn't change the efficacy, how well the treatment works, doesn't change from Epley to Gans to Semont or any of these other kind of things. It's simply the comfort level and the safety of the body of the patient. Okay, so now we're going to show you the actual treatment maneuver that we're going to cover today. This is the Gans repositioning maneuver, again, developed and named after Dr. Richard Gans, founder and executive director here at the Institute. This was, again, developed as a hybrid of both Semont and Epley's maneuvers. So he's going to start the patient in a side-lying Hallpike position with the patient on their right side. And you can see he's also using a bed sheet. You'll see why in just a few seconds. So he's got, again, rather than having the head off of the back of the table, he's supported. The shoulder is creating the verticality necessary of the ear. He's waiting until nystagmus and vertigo stop in this position. And then he's going to proceed. So now he's going to actually roll the patient all the way to his left side, again treating a right ear here, and he's going to use the sheet as a means of creating a mechanical advantage. So he uses the sheet to roll him. So you see components there of the Epley maneuver, rolling him over, he's also implementing a little bit of a head shake there to reduce recurrence rate. And now what he's going to do is he's simply going to sit the patient up. And those of you who are doing Epley's maneuvers currently, you can see how much more comfortable and more biomechanically sound this treatment actually is. So perfect for patients who maybe are bariatric, maybe they're large, maybe they have issues that prevent them from rotation or hyperextension, maybe they're just nervous. But regardless, we find that this is a wonderful alternative that you can use with your patients that have some of these issues that we've discussed without suffering anything in terms of the efficacy. And what you're going to see if you use the Gans repositioning maneuver is you're going to see reduced rates of horizontal canal migration, you're going to see reduced rates of recurrence, and you're going to see more comfortable, happier patients with the outcomes. And again, I want to make sure that we're always putting our focus on evidence-based science. These are just a couple of the articles that have been done publishing looking at if you use the Epley versus the Gans repositioning maneuver, the Gans versus the Semont maneuver, the advantages of this hybrid maneuver. Again, this has been studied relatively vigorously. So we're not teaching you anything that's just, we believe that this is a good maneuver. This has been studied, and the science is very, very clear. So again, if you would like to learn more, like I mentioned, we do an entire afternoon dedicated to nothing but BPPV, hands-on, laboratory-style education during our certification courses. So if you'd like to learn more, we'd be happy to have you down at the Institute or at any of the various cities that we travel to and certify professionals. We'd be happy to have you, and we can share a lot more of this evidence-based knowledge that we've talked about. Thank you for attending our little session today, and I hope it's given you some interesting stuff to think about going forward when you're managing and treating your dizziness and vertiginous patients. Thank you.